Hello, everyone, and welcome to the second day of 12 CEUs of Christmas. I'm Diane Cohen, Vice President here at MacroPro and the Dean of Education. I want to start out by thanking Drew Davis for saving me yesterday. I had some Icelandic gnomes that are known to be very mischievous and naughty, and they knocked out the power here where I live, so I was unable to attend. In addition to that, I had a flood in my home, so today I'm here in my kitchen because my office is being repaired. So it's been kind of an interesting December for me. Today I'm joined by Jim and Clint, and we're going to talk a little bit about what they do with H-Wave, and Clint's going to be our speaker, and he'll tell us about the technology on that. But before we do, I just want to remind you a few things. First of all, this webinar is worth 1 CEU. You have to be logged on with your own link. And I notice here that someone is using a link 3 times, which means these 2 people are not going to be getting a certificate under their name. It's going to be under Brenda's name. So you want to make sure to use your own link so the certificate shows up for you. You should get that CEU within about 1 hour. If you don't receive it, please let me know. I can help you up to 30 days. In addition to that, if you have any questions, this is a very interesting topic, please go up to the control console, look for the little question mark, and Jim will be asking Clint those questions today. So feel free to ask any questions. Make them really nice and hard, please, because these guys are on it. They've got their answers ready to go. And then at the end, I'll remind you of some of the other classes that we have coming up this week. So Jim, Clint, welcome. How are you guys?
Wonderful. Thank you.
So,
very good.
So, Jim, where are you located?
I'm in Huntington Beach, California. So just to introduce myself, Jim Heaney. I'm one of the owners of Electronic Waveform Lab. We are the manufacturer and provider of the H-Wave device, and I'm sure some of you are familiar with it. I'll just do a brief little intro. Electronic Waveform Lab, we are in our 45th year of business. We are a family-owned and operated company. Still 100%, me, my brothers, and my father still retain 100% ownership, and really like to make sure everybody gets that family feel if they are a patient that utilizes the H-Wave device. Obviously, I have Clint on here because I don't want to give you a sales pitch on H-Wave. So Clint is a licensed physical therapist, over 14 or 15 years experience. The way we were introduced to Clint does a lot of work with the military. He's done a lot with Rangers, SEALs, Green Berets, also worked with MLS players, NASCAR, NCAA, and Clint got introduced to H-Wave years back and clinically was just seeing great results. That's led Clint to do a little bit of consulting for us, but the great thing about Clint also is he is an expert on electrotherapy and physiology and how electrotherapy interacts with the human body and what works, what doesn't work, what works in certain situations better than other devices and things like that. So Clint has gone through and put together a really nice presentation on navigating the sea of electrotherapy, and we're happy to have him. And with that, I will turn it over to Clint.
Awesome. Thank you so much. That's very kind. So, yeah, full disclosure, I'm a physical therapist. I'm not a sales person. So I want to share with you a little bit from the clinical side and from the compliance side, how we may navigate selecting the right kinds of interventions for the right person at the right time. That'll be kind of my thesis as we go through. So a little bit of a background for me, just a bit more. The nice headshot on the left there is, you can kind of take your pick. Do you want the suit and tie? Do you want the hair down or up? But that's a formal little glimpse into my professional look-alike. Currently, I run an out-of-network cash-based clinic called Performance Collective. I do work with all sorts of athletes and even active agers that want to still be a lifestyle athlete as they continue to grow into their 40s, 50s, and beyond. Also, I recently this year started Global Physio Training, which is a nonprofit organization, and we provide educational resources to low economic resource populations, both domestically in the U.S. and internationally. We have a partnership with a group in Cameroon in Africa, which has been really cool. So in that capacity today, I do have the header on the slides here. Just Global Physio Training is it's a big piece of what we do to do things like this, teach others how to navigate the healthcare education system and how to provide those resources to people who need them and don't have access. So let's hop in here. I already said this, but my goal today is to explain a bit of this multimodal approach, and I hope I can define that a bit more, not just using modalities, but also using different therapies, exercise, soft tissue, manual therapies, and so on and so forth. But the goal really is to identify the right people and the right interventions, and then schedule them at the right time. So I'll say that a few more times, but the main objective for you all is I want us to understand what outcomes for your work comp cases and your patients and your clients, what outcomes are you trying to address? Are we looking for pain control? Are we looking for post-op outcomes to shorten that healing time or maximize that healing time? And a big thing for the work comp world is a return to work. Like how quickly can we get this person off of our caseload, close this claim, and not just push them back into their job duties, but maximize how well they're going back to work. So that's the main objective for today. And I want to start a little bit with just some of this conversation about what PT can do, but also how we would use modalities in accomplishing those outcomes. So essentially, the way that I use the H-wave device in particular is to prevent further loss. This information comes from a colleague of mine named Gary, and really we've agreed, and I've learned, like, there can be secondary injury, secondary cell death and tissue death when this area stays inflamed and stays congested for a longer period of time. When we put braces and splints on people, we don't let those muscles work like they should. We get some disuse atrophy. If we're not stressing those tissues appropriately, we get adhesions and scar tissues. And overall, those are natural body processes, but when they accumulate and they stay in the area too long, you get other issues, secondary and tertiary effects that really could be preventable. And then next, our goal is to regenerate the tissues that have been damaged. And the super cute, nerdy word here is angiogenesis. That means we're able to load tissues appropriately to promote circulation and blood flow so that we get some sprouting of those blood vessels back into those areas to regenerate the tissue. So that's really what I have found most successful in using the H-wave, and we'll talk about some of the electrophysiology in just a minute. I'm curious. I would ask this question if I was teaching to a whole room of you, but since I can't really hear your feedback, I'll ask rhetorically, what's the recommendation when someone gets an injury? Well, classically, we say, the RICE method, right? Rest it, ice it, put a compression wrap on it or a splint or a cast, protect that area, and then elevate it, and let's use some medication to manage some of the pain and the symptoms. But essentially, when you have an injury, the first step in the inflammation process is bleeding. That checks out. There's some regional bleeding. If you cut your hand open, you have a little blood, you put a cotton swab on it. But that's the first step of this inflammation cascade and this healing process. The healing and inflammation cascade go through a series of predictable factors, but essentially the bleeding should stop very soon. The inflammation should be working its way through that progression over the next couple of days. And then essentially we have a remodeling and proliferation phase where those cells and those tissues begin to remodel and heal themselves. And what's unique about this is sometimes we get stalled out in this inflammation stage because we rest, we don't load the tissues, we protect it, we don't want to hurt more. And that can really mess up the next couple of phases, which really get us back to functional performance and the outcomes we desire. We have to get to remodeling, we have to get to proliferation phases. So what gets in the way of healing? I think these things do. When we rest, we don't load the tissue. When we ice it and we cool it down, we create that congestion sometimes. We compress it. There's really no recommendation on how much to compress or how much pressure to add, or we can protect it and put it in a splint, but like at some point we have to get out of the splint. If you elevate it, great, but then you're messing with the blood flow supply. And so again, my colleague Gary has said it's easy to impede healing, but fortunately, the opposite is also true, and that's where my use of H-wave kind of comes on the scene. This is the folklore, just another example here of Gabe Merkin and his RICE protocol, rest, ice, compression, elevation. And what's unique about Dr. Gabe Merkin is he initiated this many, many years ago, but just in the last 10 or so years, he's actually recanted it, saying, you know what, I'm wrong, rest, ice, compression, elevation is not actually the best way forward. And we use a term called active recovery that seems to be the best answer now, meaning you're not going to have an injury in your knee or your foot and then go run it off, you know, and just go on a 5K. But we can start to expose that area again to load, to some forces to help those tissues regenerate without compromising and re-injuring those structures. So give me just a moment to be super nerdy for just a second. I want to communicate this in a way that I think is digestible for us to understand. There's a term in my world and in the physiology world called mechanotransduction. Mechanotransduction means that mechanical forces, physical forces are transduced and they're changed and converted in the body to chemical signals, electrochemical signals. So the word for this is mechanobiology. And what happens here is on the left-hand side, you can see any mechanical stimulus creates a force exchange to tissues. Those tissues then exert that force on the cells, and then the cells exert that force on the cell nucleus, and the cell nucleus then gets to make that DNA change. And what's really cool here is you get cells signaling other cells. That's where that kind of reddish box, there's a feedback loop there. And then you also get that DNA information to signal across the cells, so you get a whole tissue change, and that's the extra large feedback loop there from the right-hand side all the way back to the left. So simple principle, it gets pretty technical if we want it to, but for the sake of this discussion, any physical stimulus, mechanical stimulus, creates this same exchange on tissues, on cells, and it's DNA. So you can use manual therapy as an example, you could use exercise as the example, you could use H-wave as the example. Those forces exert on the tissues, the muscles, the nerves, the connective tissues, even the scar tissue. Those forces then stress and strain the cells with a shear or a compression or a stretching force, and that's what's necessary to take the mechanical force and convert it to a chemical signal where the DNA has to make the change. The example I'll give to you is if you lift weights and you're doing a dumbbell curl, you are mechanically stressing the bicep. That muscle tissue signals the cells of each muscle, the cells of the muscle tissue, and your body goes, hey, I need to either be bigger or stronger and recruit more fibers to accommodate and to handle that load. So that's a brief example and a super easy example of how mechanical forces make their way into the body to then have the chemical conversion to make those cellular changes. So why does this all matter for the work comp space? Essentially, I've said this before, we want to figure out the right modalities to use for the right person at the right time. And really, in my world and in major medical right now, we drive these decisions by evidence-based medicine, meaning what does the research show is the best to be used here? And in the absence of high quality research, what's our clinical information show as well? When it comes to exactly the ODGs and those guidelines, if we don't understand what we're trying to accomplish, we may incorrectly categorize devices, and then that turns into denial, increased cost, increased time for these claims to be processed. So really the bottom line is the ODG define what's reimbursable, not just what's safe. And spoiler alert, it's the FDA that says what's safe to use and what's not safe to use. In the hierarchy of evidence, the top tier of evidence is a systematic review and a meta-analysis. And again, the nerdy part of me knows and wants to convey to you, clinical case reports, expert opinion, those are lower tiers of evidence. Then we have like clinical trials that go down. Then we have randomized control trials. But essentially, the top is studies of studies. We have systematic reviews that look at a bunch of randomized controlled trials, and then meta-analyses, which look at a bunch of systematic reviews. So essentially here, if we can find information that exists at this highest tier, we have the best evidence to then make decisions with that information. When it comes to navigating the guidelines, the FDA is the one, of course, that clears a device to be safe to use. It's the ODG that helps to translate that information into, hey, what devices are best for functional outcomes and how do we recommend them appropriately? The provider and the payer then interact to choose these devices and have them coded correctly for reimbursement. And again, when we don't have this categorization maximized or efficient, it creates denials, it creates a longer lag time, resubmissions, and overall extends the whole timeline of the journey for that particular patient. Now, how does the ODG form its guidelines? The ODG forms guidelines based on that highest tier of evidence, the systematic reviews and the meta-analyses. Those systematic reviews are then graded or assessed for quality and quantity of their results and the consistency of those findings. And then the recommendations come down, devices and interventions are either recommended, they're conditionally recommended, or they're not recommended at all. And I recognize here that you all likely know this far better than I do, but essentially I want to process how we would get from an ODG to making the best decision for that patient at the right time. Back in the day, you all know this, TENS was one of the first eSTIM types of units to be FDA approved. Remember, FDA approved is essentially, it's safe, it's not going to harm patients to be used. And then there's a bunch of variations of TENS over the years, NMES, CES, the H-wave device, now all sorts of wearable ultrasound and high voltage stuff that comes out of there. But essentially, we have this predicate issue where the TENS is the foundation for us to point back to and say, hey, this is kind of like a TENS device. We can get it categorized under this, just like an NMES, just like a CES, and so on and so forth. But there are some major differences between how we would use these devices clinically and also how the ODG would either recommend, conditionally recommend, or not recommend them at all. Again, right person, right intervention at the right time. So the evidence threshold is very clear. The FDA states that it's safe to use. We can use this for a particular intent. It's the ODG that says, hey, we want to use these devices to achieve these functional outcomes. And then we're going to process through a few of these modalities, starting with TENS. I already said this, but the TENS was the kind of the OG, right? The original gangster of electrotherapy. Everyone knows what TENS units are. In fact, some of us use the word TENS just to describe an electrotherapy modality, even if it's NMES or H-wave or something else. So TENS becomes kind of like the word Kleenex for facial tissue. It's kind of a bit of a brand or a generalized term that is actually sometimes used incorrectly. Essentially, the cool part about TENS is it's pretty effective for short-term pain relief. And clinically, what I see is the patients go, yeah, my back feels better, but as soon as I take the TENS machine off, my pain comes back. And it's like, right, because the TENS machine is safe to use and it has a really predictable way of giving you a short-term stimulus so that you don't feel and appreciate that sensation. But as soon as the TENS machine is gone, boom, shakalaka, that pain's still there. It was just masked. Spoiler alert, it's kind of the same way with medication, right? You take some of the pain meds, you take an NSAID, and you have that block of the pain sensation for a short period of time, but eventually you haven't fixed the problem, the pain comes back. So here are a couple of citations, and really throughout this whole presentation, there are multiple studies cited here, and if any of this kind of sparks interest for you and you want to check my work, please feel free. They're all listed here, but essentially in 2022 and 2019, these articles support that TENS actually has inconsistent results, and it doesn't really help us get people back to return to work status. Next is interferential current. The unique part about these types of forms is as you have those pads placed over the painful area, you get a target area right where those waves cross, and that's supposed to be the best for managing a bit deeper, so to speak, pain relief. FDA says you can use it for chronic pain. The ODG says it's not recommended. And essentially here, two more studies, minimal benefit and really no additional functional changes when we use an IFC device. Furthermore, NMES or electrical muscle stimulation, this is oftentimes in the clinic, MES in particular, is used for muscle re-education. And I said this earlier as far as like the atrophy, the disuse atrophy kind of comments. We can use STIM to help turn on those muscles from the bottom up. Of course, from the rest of normal physiology, the muscles turn on from the brain, there's an impulse that fires, goes down to the spinal cord to that muscle and turns it on. So NMES can be useful to help to engage that muscle to create or reconnect that peripheral muscle with the brain. But again, the ODG says it's not a long-term solution. We're going to use these things for a short term to reconnect those tissues. But then long-term, we have to figure out other modalities to maximize those functional outcomes. In 2017, nice study here by Steen, there are strength gains, meaning that the brain now can turn on those muscles again instead of going bottom up with the unit. I'm sorry, with the eStim unit, but no true functional carryover. Next, we have CES and the MENS, which is the alpha stim. The FDA has approved those. In fact, I used alpha stim when I worked with the military personnel quite a bit. They used it for the sleep and the anxiety, the overall just kind of emotional, behavioral kind of health stuff. I personally, my own personal experience, I did not have very good experience using an alpha stim for pain control at all. I don't know exactly why, but essentially here the ODG kind of says the same thing. It's generally not recommended. Evidence here, minor results, placebo level outcomes. Perhaps that's what I've experienced is a placebo level outcome, and these high level operators and special forces guys are like, hey, I can't feel this wave. I don't feel any different. It must not be working. And it, you know, it didn't outperform placebo for those guys. Ultrasound, maybe you're familiar with, of course. This is a more a deeper level of electromagnetism where you're getting a deeper penetration of those electromagnetic waves into the tissues. In general, there's a neutral recommendation here, or not recommended at all from the ODG. Evidence supports chronic low back pain. There's no additional benefit compared to exercise alone, and that again is the multimodal approach. Most of what we do in clinic doesn't work in isolation. Whether you're talking about, you know, chiropractic spinal adjustments or manipulation, you're talking about soft tissue massage, or you're using the cupping stuff, or dry needling, or exercise. You know, very few things in rehab world really work in isolation. So certainly here, the ultrasound does not work compared to if someone just moved better on their own. Strong placebo effect. Again, it's kind of funny. There's several anecdotes I could share with you, but the one story I'll tell you about my placebo ultrasound was I had a patient come in with elbow pain, and she was like, oh my goodness, my last therapist that I went to, she was so sweet. I loved her. She did that ultrasound. Can we do the ultrasound on my elbow? I really think it'll help. And so I was like, sure, that's fine. So I set the whole thing up, did the whole thing, you know, the whole treatment. And I look over, and for some reason, I didn't start the machine. It had been like 12 or 15 minutes. And I was like, okay, you know, Mrs. Jones, like, you're done, great. And I, you know, broke it all down, do on the machine, shut it off, whatever. And she goes, oh my God, this is so much better. I knew this would work for me. And I didn't tell her, I didn't have the machine on, but her expectation was, hey, this worked previously, it's probably gonna work again. And sure enough, it did, without even being on. So that's how, you know, these are just things to consider when we're looking at modalities and how we stack them together in a multimodal approach. This patient expected ultrasound to work, and sure enough, it worked. When it comes to ice and some of this cryocompressive stuff, I feel strongly about ice clinically. We can talk more about that if you want at the end, if you have some questions you want to dig into my nerd brain. But essentially, the ODG says it's neutral. It's not recommended. One of the things that lacks for me, particularly with ice and compression, is how much compression, like how much pressure do we need to like help the swelling, and how cold do these temps need to be, and for how long? Like for my shoulder or my back, is it different than like an ankle sprain? I have a hard time with this. That's poorly researched, the ice and the compression modality. Here's your snapshot here of the evidence. Maybe some early gains in the range of motion, great, but no pain differences, no differences in swelling, no differences in range of motion at 6 weeks. So like, what else are we doing for that 6-week period of time? Have you just done cold therapy and compression? Furthermore, in 2025, there are improved short-term pain and range of motion after a joint replacement, an arthroplasty, but again, no long-term benefits. And I don't remember the exact follow-up here from this 2025 article by Petrillo, but essentially, long-term benefits oftentimes in the research are a 6-week to 12-week period of time. Now, when it comes to HVPC, the high voltage pulse current. This is short, high voltage pulses. This is like a marketed for swelling control and edema control, tissue healing, and pain relief. Again, the FDA has cleared it for pain relief and for circulation, but in general, the ODG, it's not recommended except for maybe around wound care or post-surgical edema. So what that tells me about the ODG is there may be some utility in using an HVPC for the circulatory effects. If we're managing the edema, cool. If we're helping with wound care, the wound care may stall out because of that chronic inflammation status where we want to flush out the old junk and bring in the new blood flow and the new circulation. HVPC snapshot here, mixed results, no consistent functional gains. Essentially here, it's just not clinically consistent. And that's part of the issue with the ODG is not only does it need to be safe, but it needs to be reproduced and reliable for consistency and for functional gains. And then lastly here, of course, this is the H-wave device stimulation, the HWDS. I know enough about H-wave to know that the way the board is organized provides a unique waveform. We can talk a lot more about it, but it's a decaying waveform. It preferentially activates aerobic muscle fibers that are fatigue resistant. And what's cool about that is patients may be able to wear it for a long, long period of time, like hours at a time, and they take it off. Not only do they feel the pain relief, but also they don't feel fatigued after wearing like an NMES device or a TENS device. Sometimes we get too much motor response, the muscle fiber responses. The H-wave device is really cool because the way that it's designed, it preferentially activates the fibers that are not fast twitch fibers or slow twitch fibers, and their fatigue resistance, their endurance muscles, or yeah, their endurance muscles. The ODG states that the H-wave device is conditionally recommended. And here's just some of the data. I'll show you in a minute the slides here, but the question still remains, if all of these devices are FDA cleared, why aren't they all recommended? And this is going to get into the discussion here of FDA approval versus ODG guidelines. So here's your example for many of these devices, the FDA code that's used. You can reference this on your own later, but I'll just point out to you, most of these, not recommended, not recommended, not recommended, not recommended, and then H-wave at the bottom almost stands alone, and in that it has enough data behind it that it's conditionally recommended. Again, the FDA clearance does not equal evidence, and this is one of that predicate issues that I talked about at the very beginning of this discussion. All of these eStim devices track back to the original TENS FDA approval. So there seems to be this like overlap where you can market new things, you can say it looks different, but essentially they're all classified under the FDA clearance, meaning it's likely that patients won't get harmed. This is safe for use. You can use it for pain control, etc. But it doesn't tell you necessarily that it's the best device to use for the outcome that you're looking for. Now, this comparison essentially is substantially equivalent, means that these devices are equal enough to a TENS device that we can classify it under that. But what we find in the ODG is that they're clinically not the same. So substantial equivalence does not equal clinically equal. And maybe some of you have experienced that, where you've tried to insert the H-wave device on a claim and get it approved and get the payer to pay for it. It gets denied because it's not coded correctly. It's coded as something else, a TENS or an IFC or something. So coding becomes really important. But essentially here, the ODG redirects them to the true category. The H-wave is a device that is conditionally recommended, and these other devices are not. And so if you don't have the codes correct, it's going to lead to more frustration and delays and things like that. Now, the ODG does speak this different language. It's approved if the evidence demonstrates functional improvement. The ODG draws that line by focusing on measurable improvement and return to work data. And fortunately, I have a cool study here by Tring to support that claim. But essentially, FDA doesn't care about whether it gives you the outcome of return to work or better rehab or post-op recovery timelines. It's the ODG that cares more about what is it actually doing and what's the evidence actually state. TENS has set the standard, as I said. when these devices are categorized under the TENS kind of FDA, it means that they're safe to use. But again, we still have the same problem of these devices look new, the marketing is cool, it's trendy, there's a bunch of CrossFit athletes using them or whatever else. But unfortunately, the data hasn't really changed for a lot of these older and more fundamental devices. Some compliance implications. We've already talked about FDA clearance does not equal ODG compliance. If the guideline names a specific tool, then that's the tool to use. Using substitutes violates those guidelines, and essentially you're using a rebranded eStim device with no new science behind it. The ODG helps to keep those treatments inside the evidence lanes. Go back to that pyramid or that triangle of evidence-based hierarchy. The ODG exists to push us to make decisions at the top of that triangle, at the top of that pyramid. I referenced this previously, but here's an example of the denial chain, right? If the provider recommends an H-wave device 41 days post-injury and says, oh, it's like TENS, great. The reviewer may look that up. They code it incorrectly, a denial is issued, and then you have to appeal it. There's more delay, there's more cost. And essentially here, the H-wave should be used 90 days post-injury or post-failure of NSAIDs. I would challenge you, I have way better success if I introduce an H-wave early after a post-op surgery or early after an acute injury, for all the reasons why I told you at the beginning. I want to prevent the secondary cell death. I want to prevent disuse atrophy and those muscles wasting away. I want to help to clear the congestion and the excess swelling from that area. And if a patient can't stand on that limb or can't use that limb, then an H-wave is really useful early. And that's my own clinical recommendation. But essentially here, the H-wave guidelines are, the ODG guidelines are 90 days post-injury and after NSAID failure. So we'll review this slide again. We want to make decisions that for our patients at the right time that are at the top of this hierarchy. Here's your comparative table. We have all of the eStim devices on the left and what they do for pain relief, what they do for function, what they do for return to work. And so you have some options here for pain relief, you have some options here for function, but the one that really hits all the markers here, in particular that has return to work data behind it, is the H-wave device stimulation. So there are several studies here from H-wave. I find them to be from H-wave. I find them professionally to be well done. But again, don't take my word for it. The references are all here at the very end of this presentation. I challenge you, if this seems a little bit sketchy and it seems a little bit like I'm on the bandwagon, you can go check my work and I'll prove it to you. So these articles here for shoulder and knee pain, you're looking at increased range of motion, decreased pain, and decreased opiate consumption for the Blum study. In Hazelwood, 64% opiate reduction over 90 days. Functional outcomes have improved. That's a big deal. 64%, you're looking at almost 2/3 opiate reduction over 90 days. I have most of my patients hate being on the stinking opiates. They feel foggy and cognitively impaired and all of that. So essentially, if we have an alternative that can help with pain management, this Hazelwood study shows, hey, there's 64% of reduced opiate consumption, which is pretty dope. And then the Norwood study says, hey, faster return to work, 6-month sustained results, and I'll support that with this Treen article. I love this article. It's super new. Both the Norwood and the Trend articles are very relevant in the last couple of years, which is cool. But you're looking at a 6 to 24 month follow-up window. And here's what Trend finds: 35% average pain reduction, 89% functional improvement, 41% complete opiate cessation. So not only are we reducing the opiates, like I told you about the Hazelwood study, but Trend says, hey, 41% of these people actually stop opiates altogether. Woo, woo. And then in general here, improved quality of life, changes in anxiety and reduced depression. And essentially here, return to work status, 87% were already working. So you're looking at a 6 to 24 month follow-up period, and 87% of these patients were returned to work status, which is the goal, really is the goal for our work comp personnel. These outcomes align with the ODG definition of functional improvement, and that is the key determinant for approval. It's not just that it's FDA cleared, it's that there's a functional capacity, a functional gain by using the H-wave device. These two meta-analyses are pretty cool. In 2019, this Gibson study shows there's mixed results using TENS and IFC. So remember, a meta-analysis is a study of systematic reviews, which are studies of randomized control trials. So oftentimes these are huge data sets that they're looking at. And again, I'm a big nerd, I have a big wrinkly brain, but to make it simple for all of us, that's the highest quality of evidence. And so if the evidence is mixed, it's just not substantially there or predictable over time. The current study in contrast shows that H-wave device actually has sustained benefits for the range of motion, return to work, functional capacity and return to work status, which is, again, a study of studies of these systematic reviews and randomized control trials. The evidence here drives the coverage. The guidelines aren't trying to block care, they're trying to fund what actually works. And this is an important detail. A lot of PTs, chiropractors, maybe physicians, we have our own lane of like, oh, this definitely works, and oh, this definitely works. So we have a system here that's designed to help assess the data, help us make good decisions for the right intervention to be used for the right person at the right time. So the guidelines aren't trying to just stop you from providing these devices to people. They're trying to find the pathway that works the best. So we're looking at the outcomes. We're not just marketing these claims. We're looking to remove, the word neutral or not recommended means that there's insufficient data. Not that it doesn't work, but the data is not there yet to support some of these other things. And strong recommendations really support increased function, faster recovery, and overall that turns into lower costs for the payers, which is again a huge detail. The patients get better. That's what we say we care about, but the actual financial component is really what drives a lot of these decisions. Timing is everything. Here's my little mantra: the right person, the right intervention at the right time. Electrotherapy is often called on only after opiates or injections or other surgeries have failed. And at that point, the damage is done. We have secondary and tertiary impairments and dysfunctions that have to be managed. So I recommend using electrotherapy earlier. It could be 90-day mark if that's what the guidelines say, if that's what the best recommendation is, totally fine. The guidelines don't forbid you using it earlier. I, in fact, use it very early after an acute injury. The ODG doesn't forbid this early use. The early functional restoration could shorten total claims timeline and reduce the cost, which, as I already said, is the big drivers for return to work, closing these claims, and being the most economical and cost effective. Yet still, particularly in the rehab world, electric devices are still viewed as the rehab afterthought. Like, all these other things didn't work. I guess we can try TENS, or I guess we can try something else. I think we should employ some of these things much earlier than we do. So here's your case study for a 30-day trial compliance flow. The initial ODG-aligned prescription, this is when the provider selects the named modality per the ODG. Documentation is correct, the codes are correct, and we're looking at the goal that we're trying to accomplish. Baseline functional assessments become extremely important. What's the baseline pain score? What are the range of motion limitations? What's the subjective ADL limitations? And what's this patient's return to work status? The 30-day treatment trial begins with home use 2 times a day for 7 days a week. The midpoint check-in is right around that 15-day mark. You're looking at passive range of motion. How much range have we gained? And then the post-trial evaluation, day 30 and beyond, is to compare the baseline compared to your outcome metrics, i.e. after that 30-day period of time, was there an outcome? Is there functional improvement changes, reduced medication changes, reduced pain levels per a subjective report, and what then is required for continuation? And then lastly here, as far as the decision node, if the improvement has been met, then continue or extend the use per the ODG guidelines. If there's no improvement, then discontinue, reevaluate, and change the treatment plan. Again, this whole thing is who are the right candidates for these interventions and at the right time. Lastly here, when it comes to being compliant, These guidelines help promote compliance. So we want to use the named modalities as they're written, match the codes correctly. I would recommend, since you all are not writing these notes all together, maybe one extra question to the PT provider or the referring provider, just to clarify, hey, do you mean TENS? You wrote TENS. Do you mean one of these other devices? Like, what is it exactly that you're looking for? But match the code to the documentation, align the treatment intent with the cited guideline recommendation, and then reassess continuation of those modalities on functional outcomes, not just patient preference. Functional outcomes drive everything that we do in the PT world. Pitfalls here, it's basically the same thing. We're substituting quote unquote equivalent devices that are not named in the guidelines. We throw everything in the kitchen sink at these people before we use electrotherapy, and treating without the evidence using other devices really limits the functional progress. Why not use an H-wave device, number one, early to support your plan of care, and number two, instead of a different device because of what H-wave does? I added this in here as a little checklist for you all as adjusters and as case managers to understand like what's to look for. Do we have ODG alignment? Do we have evidence of improvement? Do we have clear functional goals in the claim on file? What's the duration? Is the duration consistent with the guidelines recommended? Is there documentation that matches treatment code and rationale? And what's the clear-cut pricing for the reimbursement and to communicate to the payer? In my opinion, this is your provider advantage. The guidelines align with faster return to work. In my network, or I'm sorry, in my clinic here, I'm an out-of-network cash-based clinic. I want people back to doing what they need to do faster. I don't get paid per visit, $100, and have to manage the volume of a traditional in-network clinic. But this is something that's different about my setup professionally. We want these people to be off caseload faster, even if the PTs and the other larger institutions want to keep them around and keep suckling off the financial resources. This is a nice way to shorten that gap and to manage the economics, but then also to have the evidence to support better functional outcomes and return to work. Again, the advantage here, streamlined approvals, fewer denials. That means you had everything coded correctly on the front end. Well done. This builds trust with between the adjusters and the nurse case managers that, hey, I don't have to scrutinize every stinking line of this anymore because now I know these nurse case managers are doing their due diligence on the front end. And then lastly here, we reinforce the outcomes-driven care model. And sometimes in healthcare, we say outcomes-driven care model. We don't really mean it. We mean kind of sick care, keep them well enough, but they have to still keep coming back. This device can really set you apart to actually have outcomes that you want, to pay less for the total claims, manage the economics. And really, it's best for the patient. It's best for the patient. So finally here, our takeaways. The FDA clearance does not equal the ODG guidelines. FDA clearance does not equal clinical endorsement. The ODG looks at function, not just the marketing of trendy devices. And conditionally recommended does mean that the evidence, it keeps the information referring to evidence, not just brand favoritism or not just classy and trendy marketing. Conditionally recommended, we're looking at what the evidence actually supports, not how well the marketing is done. So wrapping it up here, here's my objective summary. We talked about this at the very beginning. What are the outcomes that you're trying to address with this particular patient at this particular time? Is it pain control? Well, we have a device that does that. We can reduce opiate prescriptions, which is awesome. We don't have to wait until those pain meds fail. Are we looking for post-op outcomes as far as how well they are after a surgery? And we're looking at rehab status as far as getting returned to work. Hey, we have evidence that supports that. Why use something different to kind of cobble together a solution when we already have the right solution right in front of us? And really, in my world, this supports the patient by selecting the best interventions and devices for the desired outcome. If it's just pain relief, fine, buy a different TENS unit, whatever, that's a short-term outcome. I already showed you that data. But if you want the pain relief and the functional outcomes and the return to work, the answer is pretty clear as far as what the device is to be conditionally recommended and to be used. My own clinical recommendation is to deploy the best fit electrotherapy device early in the case and the plan of care. These are modalities for pain control, circulation, and healing. But again, I can't state this enough. I have had way better success if I can get to an acute injury or a post-op patient with an H-wave device early. It doesn't affect the surgery. It doesn't risk any of the anchors coming out, or there's no correlation with failure of those joint replacements or whatever the things may be. Using them early, it's a submaximal contraction. It's anti-fatiguing. It's the perfect device to use for getting these outcomes earlier in a plan of care, instead of waiting until the 90-day mark or the 120-day mark, where then you have so much more you have to undo in a clinical situation. Lastly, for these references, I told you I would not lie to you. I put all the references here. If you have a bigger brain than I do, awesome. I would love to field these questions, but here's your kind of homework to process through. And don't take my word for it. Go and do the reading on your own if you wish. I'll pause here for a moment and just say, what questions, comments, concerns do you all have for me?
I don't see any questions in the chat.
Yeah, so currently we don't have any questions, but maybe we could just visit for a few extra minutes. We need to go at least 50 minutes in order for us to provide those CEUs to our attendees, and we want to make sure they receive that. I would like to share a story, though. I was at a conference many years ago, and I had a lower back issue, and I was really having problems with it. And in between visitations, when we would be at the booths, when everybody was in class, I would go over to the H-wave booth, and I would sit there and I'd have those pads on my back. And I'm telling you, I was a new woman at the end of that conference. It was fantastic. It really worked well for me. And I know I always heard a lot of people saying, does it work? Doesn't it work? And I'm here to tell you that it worked for me. And I was really excited to have that.
There are a couple questions in here. One was just about H-wave cost. The purchase of the device retail is $3,960. We are contracted with most of your PPOs, so there's always at least a 20% discount there with that. Plus, we'll always work with a payer to do some direct pricing and keep those costs down. And then Clint, there was one other question for you. It says, how often do we need to have a separate eStim unit outside of PT?
Does that mean like sending it home for home use, do you think? Or is that...
That's what I'm assuming on there.
So, okay, I mentioned this at the beginning, but one of the ways we think about ways to promote healing is that active recovery, right? So like you may be familiar with athletes on the sideline at a football game, and they kind of tweak their knee or tweak their ankle, and they're on the stationary bike, just kind of staying warm, letting the body, the blood flow circulate and all that. It's hard to get it's hard to get a stationary device in my backpack and like ride the bus home or ride the plane home, right? So there are other tools that would work in a similar way. I like the H-wave device because it's extremely portable. You can toss it in your backpack, you can toss it in a piece of luggage or whatever. And then what you get the chance to do then is, instead of having to be at a gym, at a PT clinic, doing your rehab, you have this ability to maintain that therapeutic window for a much longer period of time in between actual whatever PT rehab treatments. Professionally and clinically, I prescribe it as long as you want to use it. Just like Diane, my anecdote is I'm a 38-year-old dude with some intermittent back pain. And when my back flares up, I will actually, I don't know if I should say this, I guess, on recording, but my own personal and clinical decision is I sleep in the H-wave device. I put it on my back. I'm a back sleeper. It's like I'm sleeping in a coffin all night, and that's just who I am. But I find it the low intensity setting to be a nice, gentle, kind of soothing little pulse. And usually around like 3 a.m. I wake up and my body's a little bit annoyed of having the sticky pads on still, so I'll shut it off. But essentially what I'm trying to say is I then get the benefit and the therapeutic benefit of helping those muscles regenerate, helping that circulation, manage that inflammation process so that the right factors are getting there at the right time, and then they're flushed off. It's not swollen, it's not chronic and persistent, but I'm able to kind of exploit the therapeutic benefit there while I'm sleeping, doing nothing anyway. And I end up waking up much less stiff, much less painful. and it shortens my acute injury flare-up window. Oftentimes, a back pain flare-up may last 5 to 7 to 14 days. For me personally, when I wear it at night for 2 or 3 nights in a row, I'm pretty good at like day 3 or 4, back to like my baseline. So that's a long way around of answering. Having it in the patient's hand to be able to be used as needed, PRN, or as often as they want, is super useful, and it only exaggerates the therapeutic benefit of whatever we're doing in person for that patient during a PT treatment.
I can testify to that. I'll tell you, we have our machine, and sometimes, if my husband's back goes out, he'll be wearing it for hours and hours, but he's only going to be out for a few days, not for a few weeks like he has in the past. All right. Well, I want to thank both you and Jim for being our guest today. I have a few other announcements to make for our attendees. And I do hope that all of you have a great and fabulous holiday. And Clint, you are back east, right?
Yes, I'm in the Charlotte market. I'm just south of Charlotte in Fort Mill, South Carolina.
Okay, so it's getting cold for you there.
Yes.
I did want to answer one other question, and Clint, you might want to answer this. It just says, is the device safe to use every day, and for how long?
So, Jim, you can tell me the exact recommendations for how long, from a device perspective, from a clinical perspective.
Usually 30 to 45 minutes per treatment, 2 times
Perfect.
a day is like the general protocol when they first go home.
Yeah. So for me, I will tell patients, use it as often as you want. I like it to be more than 30 minutes because I want to maximize the benefit. So like 30 to 60 minutes is kind of the minimum I would recommend, but then I don't really recommend a maximum because of what I know about how it isn't fatiguing, and it's not maximum, muscle activation. So my prescription is like, if you're going to do it, you need to do it for at least 30, 45 minutes, 60 minutes, but also you can do it as long as you want.
Very nice. I could attest to that one. All right. Well, thank you so much. This was very interesting, and it was great to hear the clinical side of everything. All right. So this week we have other fabulous webinars coming your way, including Medicare Mayhem and Milestones. This is going to be tomorrow. We've got Mastering the DIR website, and that's always very popular with Chris Bowen. In addition to that, we have a couple of really cool webinars that are a little bit different than our typical. This one's called Glow Within. It's a work frame for personal empowerment and self-sustaining growth, which is awesome because we all need that in our industry. We have so many things we need to know and understand that we could get so fatigued. So if we can get some help with how to grow and empower ourselves properly, then I think it won't be so fatiguing on us. In addition to that, we have Unwrapping the Layers of Medicare Medical Reports with Leslie Dilbeck. She's always outstanding. And then we have with Carl Van, and I think every single one of you should be signing up for this if you haven't yet. It's called Keeping Calm in Claims, Managing Stress for You and Your Claimant. And I don't know what more we can get. I think that's like the best gift we could give you, this entire series of CEUs, right? Because this can be such a time of stress for so many of us. And I know our jobs are very stressful. You guys are amazing. You guys are truly amazing what you do, making our injured workers whole again, or at least as close to whole as possible. All right, everybody, until tomorrow, I will see you, and look for your CEUs in your email. Jim, thanks so much for joining us.
Thank you.
Bye-bye now.